Hi everyone, I'm Arisma and in this video I will be talking about sensitivity and specificity, the two terms that come up and are tested in all three USMLE exams and is a concept that is retained better when well understood. So let's begin. I'd like to start by talking about what sensitivity and specificity mean. Sensitivity is basically finding out that of all the people that have the disease, how many of them test positive. On the other hand, specificity can be considered the complete opposite of sensitivity, where I'm trying to find out of all the people that do not have the disease, how many of them test negative. Let's now delve further into the concepts of these two important terms. For syphilis, an important screening test is VDRL. Now, for example, in a small community, there are 600 people, and among them, 100 people are considered to have syphilis. With the VDRL test, I find that 90 out of 100 people test positive for syphilis, which means 10 people fall into the false negative group. As we can see from the table, among the 100 people, 90 people test positive, and therefore they are true positive, while the rest 10 people are false negative. Putting the numbers into the equation for sensitivity, which is true positive divided by the sum of true positive and false negative, we get a sensitivity of 90%. That means among people with the disease, the VDRL test will be positive for 90% of these people. Moving on, we know that a highly sensitive test helps in ruling out a disease. Well, how does it do that? Let us look at an example. Suppose a test is 100% sensitive. That means it will be positive for all the 100 people with the disease, which in turn implies that if anyone tests negative with this diagnostic test, we can be sure that they do not have the disease. In this way, the test helps us rule out a disease. Similarly, in terms of screening, we would like to have a diagnostic test that is able to test positive for all the people who have the disease, and thus sensitivity is an important metric in finding out the best screening tool. Let us now look into specificity. For syphilis, the fluorescent treponemal antibody observed is used as a confirmatory test. As before, among 600 people, 500 people are considered to not have syphilis, and among them, 400 out of the 500 people test negative. This puts the rest 100 people in the false positive group. Moving on to the table above, we can see that 400 people are true negative, while the rest 100 are false positive. Using the formula for specificity, which is true negative divided by the sum of true negative and false positive, we get a specificity of 80%, which means that among people who do not have the disease, the fluorescent treponemal antibody observed is negative in 80% of these people. Now, as sensitivity helps in ruling out a disease, specificity helps in ruling in a disease. How? Let us look into an example. Suppose a test is 100% specific, and therefore it will be negative for all the 500 people without the disease, which means if anyone tests positive with this diagnostic test, we can be sure that they have the disease, and thus in this way it is used to rule in a disease. Not all patients who have tested positive for VDRL actually have the disease. They may be positive due to cross-reactivity from another antibody. And in order to confirm that a patient has syphilis, we then order a fluorescent treponemal antibody observed test to find out. This is why tests with high specificity are used as confirmatory tests. I hope that I have been able to help out in clarifying these basic concepts of the above two terms. We'll see you soon with another video. Till then, have a wonderful time.